have three great speakers. We have three great speakers, and I believe you are all looking forward. If you get to have any question, please put it on the Q&A. Otherwise, as I had mentioned, my name is Rosalyn Okumu. I'm oncology nurse. I also chair the oncology nurses chapter, and I work at KNH Cancer Center. So you're welcome, Stephen. Please unmute yourself and share your experience. Monda, if you're able to just see if Stephen is with us. If not, we go straight to Ronnie. So Ronnie, you'll come and talk about bladder cancer, epidemiology, signs and symptoms, and then you'll wind up at a later point with the advice you give the patient through the navigation process. So Ronnie, please welcome.
Thank you, Rosalyn and Kenco and KNH and Janssen for organizing this webinar. My name is Ronnie, as you've been told. I'm going to take you through bladder cancer. So I'm going to, in my course outline, you'll assist me move the presentation kindly. So I'm going to talk about bladder cancer, and it is wise that we know where the bladder cancer is located in the body anatomically, and the epidemiology of bladder cancer. What are the risk factors for and signs and symptoms for bladder cancer? The various diagnostic modalities that we use in management of diagnosing bladder cancer and bladder cancer survivorship. Dr. Komen will take us extensively on the various treatment modalities. So when you look at the location of bladder cancer, and also the anatomical location of bladder, the bladder is located in the pelvis. The bladder is located in the pelvis, and the pelvis is on the, actually from the kidneys, you have the ureters, then down is a hollow organ that now its role is to collect urine and empty urine. So that is the anatomical location. As you can see, it's just proximal to the kidneys and also proximal to the prostate. So it collects urine and then it empties because it's a muscular hollow organ. You can appreciate the image. So that's the role of the bladder, collecting and storage, and empty of urine. So when we go to the epidemiology of bladder cancer, we note that bladder cancer is one of the leading cancers in the world, because when you look at men in terms of the statistics, you note that men are prone to bladder cancer. And according to the Global Can data 2020, it is ranked as the 20th most common cancer. And in Kenya, with an estimated 493 new cancer cases that are diagnosed yearly, that is per 100,000 people. And that makes an approximate 1.6% of all new cancer cases that are diagnosed. And you realize that in terms of mortality, bladder cancer causes approximately 246 deaths per year. And when you look at that figure, you'll note that it's approximately half of all bladder cancer cases. When we diagnose them, almost half of them will succumb to bladder cancer. And unfortunately, we have our Nairobi Cancer Registry. We don't have recent data. But when I looked at the data from Nairobi Cancer Registry from 2004 to 2008, where I noted that males were more prone to cancer, and 53 males per 100,000 and 26 females per 100,000. But when you look at the trends, you realize that the cancer cases have been increasing significantly. And worldwide, we note that it is the fourth most common cancer in males. Prostate is the leading cancer, but in Western countries, it is the second urological malignancy after prostate cancer. And the reason is we note that in Caucasian population, bladder cancer, bladder cancer is more prevalent, unlike in the other ethnic communities. So it's more prone in Western countries. But we've had cases, an uprise in the number of cases that are diagnosed. So when you look at the survival rates, you note that the survival rates of both sexes, the red indicator, the red bar is an indicator of both sexes. The blue bar is for female, and the green bar is for male. So when you look at bladder cancer survival rates, you realize that all cases, the survival rates in males is slightly lower compared to females. And then when you look at in terms of localization, you realize that females tend to have more localized cancer, and at diagnosis, you realize that their health-seeking behavior is better than most of the males, and also regionally, you realize that females also have lesser spread. But in terms of survival, we note that as you continue getting ill, those who have distant metastases to cancer, they tend to have a lower survival index compared to the other localized diseases and regional disease. And that is according to a study that included all races and all ages. So I'll look at the signs and symptoms, but I want to take us through one case, several cases. We have a 33-year-old female patient who presented with intermittent hematuria and unspecific abdominal pain. And on physical examination and routine tests, an ultrasound scan noted a lesion, which on cystoscopy confirmed a histological grade 2 papillary transitional cell carcinoma of the bladder with no invasion in the lamina propria, which means this was a localized disease. And when you look at her occupation, she was a full-time hairdresser at Kitengela. So we have also another case of, the second case is of a 58-year-old lady, is a resident of Mwea. Her full-time employment is, she's a full-time rice farmer, and she developed hematuria and urgency in urination. And the biopsy showed that they diagnosed bladder squamous cell carcinoma. And I think we have another case, and the case is of a 69-year-old male patient, a 65-year-old male patient who had a long history of cigarette smoking, and he presented at cancer center with a history of 8 months intermittent gross hematuria, and they diagnosed muscle invasive urothelial bladder cancer. And she has also other comorbidities, diabetes, and she has also coronary heart disease. And so when we look at the risk factors, we'll keep going back and forth. We have several risk factors. And in our first case, we had a hairdresser that was her main occupation. And when we look at the risk factors, you note that apart from Occupational hazards can be a risk factor. Other risk factors include bladder stones, high urinary pH, and that might be precipitated by inadequate intake of water, recurrent and chronic bacterial infections, cigarette intake, pelvic radiotherapy, and high cholesterol intake. Other factors include occupational hazards, and you can assist me move the slides. Other risk factors include advancing in age, personal family history, previous cancer treatment, chemotherapy, gender, bladder birth defects, race and ethnicity. And when we talk about the risk factors, and when I want us just to go to we'll go back to the cases later, but let me just go through the risk factors, and then we'll discuss later on the cases that I've mentioned. So these risk factors, let's talk about smoking. Smoking is a risk because we can divide these risk factors into two, and those that you can be able to modify, and those that you cannot be able to make adjustment on. So when we categorize them into two broad categories, we realize that it is wise for us to work on the ones that we are able to modify, because the ones that you can't modify, most often you have no power over. But the ones that you can be able to modify, you are able to work around them so that you are able to prevent getting bladder cancer. So on the non-modifiable risk factors, we note that advancing age is one of the risk factors. And why advancing age? As you age, we tend to have a cumulative effect on genetic mutations. We also have issues with the comorbidities that will arise that might alter your immunity. And so you are likely prone to get bladder cancer. And another factor is we are talking about age. Apart from age, sorry, we are talking about issue with the family history. We have had various somatic mutational studies that we note that when you have a defect in your genetic conformation, you realize that over time, the regulatory mechanism in terms of cell division, cell control, those checkpoints are affected, and likely you become prone to cancer. And you can see another hereditary non-polyposis, Lynch syndrome, or hereditary non-polyposis colorectal cancer. Lynch syndrome has been linked with the colorectal cancer. So those who are at risk also of Lynch syndrome become prone to bladder cancer. And also we've had cases of retinoblastoma diagnosis. Those who have had a history of retinoblastoma are also prone to cancer. And then we have race. I've talked about Caucasians are more prone than African American and Hispanic population. In terms of gender, the males are more prone. Why? Because of occupational hazards. They tend to work in areas that they tend to be exposed, and because of lifestyle related issues with smoking. And then we have bladder defects. Birth defects have been linked to bladder cancer, and one of the blood defects is extrophy, bladder extrophy, and that happens at birth. So the ones that you can be able to modify, we are talking about cigarette intake. And cigarette intake, we can see from a case with a long-standing history. When you go to the case, you have seen a case of a 60 male patient who had a long-standing history of cigarette intake. And when you look at that case, you note that he had smoked, he had over 20 years history of pack history of cigarette intake. And why cigarette intakes? We note that a cigarette has over 70 carcinogens in it. So it is likely to predispose you to cancer. And then we have work exposure to chemicals, occupational hazards. We've seen the 39-year-old lady whose full-time employment is she's a hairdresser. And why being a hairdresser, we are exposed to what we call aromatic amine chemicals. And those also who work in printing companies, leather, textile industries, paint industries, they are more prone. And those who also work in who are truck drivers, because they are exposed to hydrocarbons, they are also prone to. We've had also healthcare workers, because they work, especially those who work with gases, they are also prone to cancer. We've seen our case had a history of diabetes, other underlying comorbidities. They are likely to suppress your immunity, and the long-term use of steroids. And then we've seen that case of a lady in Where, whose occupation is rice farming. And why is she at risk? It is because she's exposed to bilharzia, schistosomiasis, hematobium schistosomiasis. That is a risk of that is a risk of bladder cancer. Those who have recurrent and chronic urinary tract infections. And apart from that, we have seen gynecological TB, extrapulmonary TB, and the likes of genitourinary tuberculosis being a risk in itself. So I'll move to, you can assist me move the slide. I'll go faster because of time constraints. So the modifiable risk factors: inadequate fluid intake. Those who don't take adequate water. Why? Because when you look at the metabolism in the liver, there are several processes, and the toxins that come are collected in the bladder. And when you don't empty your urine is likely to precipitate, and also because of the toxins that are found through the metabolic activity, you find that you are likely to be exposed to bladder cancer. And then you have also cases that we've seen cases of prolonged in bladder catheterization. Why? Because of the chronic irritation. Assist me move the slide also. So what are the symptoms? The symptoms will vary, but the main symptom is hematuria, bladder in urine. Yeah, and you can see the symptoms are very stressful. You can see the gentleman is so much stressed. So bladder in urine is the main symptom, and sometimes some people will have their changes in urinary patterns, and you can detect this by looking at the color of your urine. But apart from that, sometimes it might not be detected from the look of the urine, but you can do microscopic examination. You're able to detect that. So the early sign is blood in urine. Other sign is frequency in urination. So can you assist me move? So the other symptoms is pain. You assist me move further the slide also. Yes, the main other symptoms is weight loss. As the disease continues to work on your system, you find that you're likely to lose weight. You are likely to lose appetite. You will be fatigued. There may be, because of invasion in the inguinal nodes, you are likely to note that there's swelling in the lower limbs. You might have difficulty in passing urine. We've noted that, because as the tumor progresses, it's likely to block the urethra and the openings. And you're likely to have metastases in the bones and the other areas. So which population should be screened? All of us should be screened, but unfortunately we have no like a standardized screening modality, like in terms of how long should you be screened. But what happens is they recommend that the very high risk population that we've talked about, the ones who work in occupational areas that are prone to, they are exposed to aromatase amines, they should be screened. Those who have had a history of birth defects and the likes of cancers, underlying malignancies like retinoblastoma, and maybe the ones who have been exposed to cytotoxic drugs, especially like cyclophosphamide, has been also been linked to bladder cancer. And then those who have had a previous bladder cancer treatment history because of the issue with the genetical and treatment risk profile. So there are various diagnostic modalities, but I know Daktari will talk about them. But the main diagnostic modality is you can do urinalysis to check blood in urine. You can do urinary cytology tests. And apart from that, there are also new tests that are in the market where you are able to do tumor markers to be able to determine the nuclear matrix protein 22 antigen. And then you can do cystoscopy. You can do bone scans for those who have maybe suspecting bone metastasis. You can do also CT scans, MRIs to be able to determine and diagnose cancer, bladder cancer. So with regards to the treatment modalities, surgery, chemo, immunotherapy, targeted treatment, Daktari will talk about them.
Yeah. Thank you.
I think I'll leave it to Daktari to take it from there.
Thank you very much, Ronnie, for taking us through the phase 1. I just wanted to confirm that Stephen, the survivor, is here. If he's here, he can share his experience quickly. Stephen, are you logged in already? So we need to be very careful to check on the signs and symptoms, the frequency, the blood in urine, and of course, also be cautious of modifiable risk factors that we have been told. Cigarette is a problem across in cancer. I mean, it's a big risk to many cancers, and we've seen even occupational risks here, like the rice farming, and even some occupation like hair dressing. So some cosmetics we might also be cautious on the kind of cosmetics you are applying. Just checking again if Stephen is here. If Stephen is not in, Ronnie, you can lower your presentation. If Stephen is not in, then we will allow Dr. Komen to proceed. Stephen, are you here? Okay, I'm not able to get his response. And he had told us about some of the signs and symptoms that Ronnie has presented here. Like he had a history of pain and not pain, but just blood in urine. It took him over 1 year to get the correct diagnosis and even to get the scannings done. So he said that from his perspective, he had taken a lot of time because even if nobody was having that suspicion that it could be a bladder cancer. If he will join us, he'll be able to explain. Otherwise, as I had told you, that Dr. Komen will be taking us through, and is a clinical stroke radiation oncologist at KNH. Thank you, Dr. Komen. You're welcome. He's going to take us through diagnosis, treatment, and general management. And I'm sure it will reflect quite on what we do at KNH CTC. So we are eager to learn and see what you can apply, Doc. Just put it in slideshow. Thank you.
Thank you very much, Rosalind, and dear colleagues. Good afternoon and welcome all to this webinar. Thanks, Ronnie, actually, for your very good presentation and deep insights. I think Ronnie has given us details on number one, how do we suspect somebody who has bladder cancer, their presentation. I think it was well captured on that. And I think Ronnie also captured well on the kind of investigations that we do in order to get the diagnosis. And also, I think he mentioned the tests that we do after diagnosis in order to get the staging. As you know, we have to get the stage of the disease first before we determine what modality of treatment that can be given. But briefly, it's important, I think, for the general public and also colleagues to know the signs and symptoms of bladder cancer. And I think painless hematuria is the commonest one, and we should always take it serious and do the necessary investigation. And the other key investigation is that we should make sure these patients are seen by urologists, because as we know, urologists are able to do what we call cystoscopy, and they're able to check whether there's any growth or any mass inside the bladder, and they're able to take also biopsy. Once they've taken biopsy, as we know, it goes to the pathologist, and pathologists are able to tell us what type of cancer it is. And as like Ronnie has said, and I think Rosalind has just mentioned, that in our country, there are two common things that can happen. I think the patient, the patient that is being mentioned from where would have a different histology, because patients who have schistosomiasis, they would have what we call squamous cell carcinoma of the bladder. But we also have the commonest one that you see, it's called urothelial carcinoma. And this one commonly also, I think we need to mention also people who work in farms, they should be careful when they're doing herbicide. Mechanization of farming is very common in Kenya at the moment. Many people want to add fertilizer, sprays, and everything in their farms. And we know this is also exposure to chemicals. And I think Ronnie mentioned very clearly, and this is one of the commonest risk factor for people developing bladder cancer. So I think people who are working in farms, we need to be careful. They need to wear masks when they're doing that, and wear protective gear when they're spraying their farms or their animals or anything. Yeah, so those are the commonest. So I think once you've gotten this is the common test that we do in order to stage and determine the treatment. One is MRI. I think I need to mention that MRI of the pelvis is superior.
Look, sorry, Doc.
Yeah.
Sorry to interrupt you. I'm not sure if you are intending to move the slides. I've not seen
I
them.
will. Yes, thanks. I will mention, I'll just mention briefly introduction, then I will go straight to treatment.
And then number two, I'm requesting that we send our questions into the Q&A section, please. Thank you.
Thanks, Rosalind. Yeah, so I just wanted to make a brief introduction because I'll go straight and talk about the management. So I think the key thing, like I said, is cystoscopy and biopsy to get the diagnosis. And the other important investigation, which I think Ronnie mentioned, but just to insist, MRI of the pelvis is the superior test. And then once we get MRI is able to tell us, to show us the bladder mass, is also able to tell us whether there are lymph node involvement in the pelvis. Then we need to do a CT scan of the chest. CT scan of the chest will help us to know whether there is metastasis either in the liver or in the lungs. So we need to do CT chest abdomen and also MRI of the pelvis. After that, I think we determine the treatment. So treatment for bladder cancer would depend on the stage. Like Ronnie mentioned, there are patients and survival, I think his graph was very clear. Patients with early stages, they have longer survival. And as we know, patients who on the other end, metastatic disease, they have poor survival. So the treatment for patients with bladder cancer, as we know, bladder is covered by a mucosa. So early stages would be patients who have disease that is just covering the mucosa. And I think Ronnie showed us a picture of the bladder. So patients who have, once it becomes more advanced, it deepens into the bladder muscles, and that is the stage 2 to stage 3. And then once it goes into the surrounding organ, it's called stage 3. And if it goes to the distant organ, it's called stage 4. So for the sake of this presentation, as we know, cancer are treated with the multimodality, is a multimodality and a multidisciplinary disease, and requires input from all kinds of specialists in order to make right decision and determine the treatment. For this talk this afternoon, I will talk about patients who specifically have muscle invasive bladder cancer. And these are patients who are called the T2, T3 patients. Yeah, and some of them have also node disease. So those are the patients actually that come to our CTC department. And there are patients that we give what we call trimodal therapy for muscle invasive bladder cancer. And I'm going to mention what this is. So just as an introduction, we know that patients who have bladder invasive mass, the gold standard of treatment is called radical cystectomy, which is done by the urologist. But most of the patients, as you know, radical cystectomy is a very aggressive surgery, and most often also changes the life of patient, because now they have a different way of passing their urine. So most of patients, sometimes they decline to have what we call radical cystectomy. And these are the patients that we treat in our department. And the aim of our treatment is what we call bladder sparing. And this is to minimize morbidity and maximize quality of their life. So their bladder sparing modality includes doing both transurethral resection of the bladder tumor, sometimes partial cystectomy, and radiation therapy, and also chemotherapy. As you can see, all this, interestingly, for us to get very good results, you need all these specialists in order to do their part so that the patient can get optimal care. So as you see down there, I've written note is that each of the modality individually is oncologically inferior, meaning that you cannot give patient chemo alone and expect to get good results, or give this patient to the surgeon so that they do transurethral resection of the bladder tumor and expect good results. So you need to combine them, and that's why it's called trimodality treatment. So the aim of trimodality therapy is to optimize oncological outcome, meaning that you need to combine them to get the best outcome. So the objective of my talk here is to highlight which patients might benefit from trimodality therapy. We'll review the components of trimodality therapy. What does it include? We'll scrutinize the outcomes of trimodality therapy. So, and in my introduction, I mentioned that these are patients mostly who have what we call muscle invasive bladder cancer. So what are the indications for trimodality therapy? So first of all, these are patients who have not had no radiation therapy contraindication. So as you know, there are patients who have what we call scleroderma, patients who cannot get radiotherapy. So these are patients who cannot be given this modality of treatment. So the patient must have no radiation therapy contraindication. Majority of patients should have what we call a transurethral resection of bladder tumor. So the tumor in the blood, inside the bladder, must be resectable. So like I mentioned earlier in my introduction, these are patients who have disease that is within the muscle, and they're called clinically T2 and T3 stage. Patients must have low volume disease. So if you have very high volume disease, most time we will refer you to the urologist, and these are patients who need what we call neoadjuvant chemotherapy, followed by radical cystectomy if it's non-metastatic. But trimodality therapy can be considered for patients who have less than 5 centimeter tumor and unifocal, preferably. So these are patients, as Ronnie had shown us the picture of the bladder. Tumor is just within one side of the bladder and not covering the entire bladder. So if it's covering the entire bladder, you cannot be able to salvage it or give this trimodality therapy, and they will require surgery. So again, no diffuse carcinoma in situ. So these are patients who are given trimodality should have disease that is localized within one side of the bladder. They should not have hydronephrosis, because this is a sign of disease has become quite extensive. And patients must be chemotherapy eligible. We are going to talk about that in the next slide, meaning that most times we use platinum-based chemotherapy. So you will want to know that the patient's kidney function is within acceptable range for you to consider. So they must be chemotherapy eligible, meaning, like I said, you cannot give either of the treatment alone. You need to give trimodality. So it must be a patient who's been selected well to get this treatment. Patient must have adequate bladder capacity and function. So like we've mentioned, the aim of trimodality therapy is to reduce morbidity and bladder function. So you cannot do bladder sparing treatment for a patient whose bladder capacity and function is not adequate. So you must assess this patient to see that it's adequate first. Again, post-treatment, like in my first statement, I mentioned radical cystectomy is still considered as the key treatment. So for patients who are given this modality therapy, most of the time, even after post-treatment, they need to be compliant with this cystoscopy follow-up, meaning they need to do cystoscopy on a regular basis every 3 months or 6 months for a longer period until we are sure they have been cured of their disease. So they must be compliant with this cystoscopy. I think this was mentioned earlier. So the histological variant, as we know, bladder cancer is not one disease, it's a different group of diseases. And that's why I mentioned in my introduction that you need, first of all, to do what we call cystoscopy and get a biopsy so that you're able to know what type of histology or what type of disease of the bladder are you dealing with in order to determine the treatment. But the common one that we see is called urothelial carcinoma. But we know there are other distinct variants like squamous cell, and this is the one that you can see being the common cause of it is bilharzia, which is a bit rare in our country, but we know in other countries like in Egypt is very common. They see more of what we call squamous cell carcinoma than urothelial because of the bilharzia. So we also have what we call adenocarcinoma and neuroendocrine, small cell carcinoma and sarcoma. The treatment that I'm talking about in this afternoon session does not include this other type of, this other distinct variant. It's mainly urothelial, which is the commonest one that we see in our country. So the principles of trimodality therapy treatment regimen, there are two principles that we follow and acceptable. So one of them is actually patient. Like we said, you have to combine all these modality in order to get the best outcome. So the first thing to do is to ensure that patient get maximum transurethral resection of the bladder tumor. And after that, the patient is followed up by continuous course of radiotherapy, or sometimes you can do what we call split course radiotherapy, meaning that you will give them a certain dose of fractions, mostly up to what we call 40 gray for the radiation oncologist in this afternoon session. And then after that, we send patients for cystoscopy and biopsy and see how patient has responded. And then patients who have responded very well, you continue and give a full dose of radiotherapy. For patients who have not done very well, you can discuss with the urologist and see whether radical cystectomy can be done. In our setup and at our department in CTC, it's very difficult to coordinate this and be able to do in a timely fashion in order to ensure that patients, we don't compromise their outcome. So we mostly do continuous course of treatment. We do not do the split course where we have to send them to the urologist for them to do a cystoscopy. We continuously give them their treatment until the end, and we assess response at the end of the treatment. So the first step in the trimodality therapy is to ensure that patients have transurethral resection of bladder tumor. So you need to do maximum safe transurethral resection of bladder tumor. Urologists have to ensure that all visible tumor is removed. And if the patient has not had complete or all the visible tumor has not been resected, then we always send them back to consider resection, because I think you need to mention that it's very important to know that for you to get the best outcome for this patient, all visible tumor must be resected. If you cannot give a patient chemo and radiotherapy who still has a tumor inside the bladder, so that must be considered first. Then after, and this has been shown to improve disease and disease survival and also overall survival from different studies. And the other important thing that we need also the urologist to guide us is to actually put a fiducial marker or to guide us on where exactly the location of the tumor was in the bladder. Because as we give radiotherapy, we normally want to give a more dose, what we call boost, to the area where initially the tumor was located. And as I said in the indication for this trimodality therapy is for patients who have unifocal disease. So this can be done well and be seen when you're mapping radiation therapy if the urologist or the surgeon has given us what we call fiducial marker, or they've described in their surgical notes to say exactly where the tumor was. So the next course after we've done, after adequate surgery has been done in the trimodality therapy, is to give radiation therapy. So the technique of radiation therapy actually differs. As we know, radiotherapy treatment that is given is determined by the capacity and the kind of machine and equipment that the department has. In our department, we always do for our patient what we call 3D conformal radiation therapy at our CTC. But we know there are other techniques which can give us more focal and radiotherapy. We have what we call IGRT, image-guided radiation therapy. The advantage for this is that it can be able to give us what we call inter-treatment imaging, which improves alignment. So as we give treatment, we are able to image at the same time and be able to know that we are adequately covering the disease and we are targeting, and the radiation is directly going to where we intend to give it. This enables us to give, it doesn't mean that you get a better outcome when you do this, but you're able to reduce the side effect because you're able to give a lesser area of or field of radiotherapy when you use an advanced treatment technique like image-guided radiation therapy. There's also what we call adaptive radiation therapy. This adapting treatment plan to changing anatomy. So all these actually can only be given in centers which have a certain machine that is able to deliver this. But in most cases in our country, almost all patients get what we call intensity modulated radiation therapy to the pelvis, where we treat the bladder, and also we treat the lymph node stations. And it's adequate actually in our department. In our department at CTC, we do what we call 3D conformal radiation therapy. The doses of radiation therapy that is given is pretty standard, and normally we would treat up to 45 gray to the pelvis. This is adequate to cover the nodal stations in the pelvis. And then after that, we normally contour and deliver radiation therapy up to 60 gray to the entire bladder. And for patients who actually the urologists have marked for us, and they have put for us what we call, in some centers, they're able to do what we call fiducial markers. These gold seeds that are able to locate exactly where the tumor was sitting. So for those patients, we can give them up to what we call 5 gray as a total dose. So the 5 gray is normally delivered just to the area where the tumor was sitting before surgery. So, but in our center, most times the fiducial marker is never put. And sometimes if we don't get proper drawings from the surgical notes from the theater, sometimes we are not able to locate weight. So most patients will get between a total of 60 gray and leave it at that, or a few patients where we have imaging like MRI that was done pre-operatively or pre-TURBT, then sometimes we use that and be able to fuse, and we are able to locate where the tumor is and give the 5 gray to that area. The fields depends on the techniques that one uses, and fractionation, normally it's a daily 1 fractions per day in our department. So the last part of trimodality therapy, like I mentioned, the first step is to do the TURBT followed by radiation therapy. But when we do radiation therapy, we always give it concurrently. And that's why when we were looking at which patients are eligible for this treatment, we said patients who can tolerate chemotherapy. So the common chemotherapy that is given concurrently is cisplatin, and it's been shown different studies that it improves local control when we combine it with the radiation therapy. But in many studies, there is no detectable overall survival benefit. But this is controversial because it depends on how the study was done. Some say it was underpowered, that's why it didn't show overall survival benefit. But many patients were ineligible due to impaired renal function in that study, or decreased performance status. So many patients were not given, they were given radiotherapy alone without. So it's difficult to say, but there are other chemotherapy that can be used concurrently. In our setup, we commonly use cisplatin, and we always look for patients who are cisplatin eligible that we combine with radiation therapy. But mitomycin C and 5-FU can be given, but we know it's a bit toxic. We rarely use in our department, but can be used. And it's been shown to improve local control, and it gives trends towards overall survival, but no significant increased toxicity. Gemcitabine has also been used with acceptable efficacy and toxicity, and also it suggests that gentler regimens are effective. So as you can see, there are different chemotherapies that can be used concurrently with radiation therapy when you do trimodality treatment for muscle invasive bladder cancer. But the common one, like I've mentioned, that is used as a radiosensitizer is cisplatin. And as we know, use of chemotherapy as radiosensitizer is not expected to have systemic effect. So the more aggressive chemo that you give for patient, you'll make them not to be able to tolerate treatment and complete their treatment. So cisplatin alone can be acceptable. So, and lastly, we know that when radical cystectomy is done for patients, and like I mentioned earlier, it's considered as the gold standard for muscle invasive bladder cancer. In that case, most patients get neoadjuvant chemotherapy. So can neoadjuvant chemotherapy be given prior to trimodality therapy? This is the question. Because some studies have shown that neoadjuvant chemotherapy is shown to improve survival by treating occult micrometastatic disease. But like you can see from all these studies, most times it's been compared patients who had neoadjuvant radical cystectomy and patients who have had definitive radiation therapy. As you can see, the difference between the two in terms of survival, yes, it's minimal actually. As you can see, 50% in one of the studies at Griffith 2011, 50% of patients who had radical cystectomy and 43 definitive radiation. And there was balance between the two arms. And it was shown to have 6% when you give neoadjuvant chemotherapy, 6% absolute overall survival benefits. So this is quite minimal considering the toxicity and the morbidity of the treatment. And the benefit is independent of definitive treatment modality. So meta-analysis done by Yin in 2016, it included studies, investigation on patients who've had radical cystectomy and or definitive radiation therapy, and 8%, there was 8% absolute overall survival when you give neoadjuvant. Yeah, it's mostly widely accepted to use neoadjuvant chemotherapy for patients who have, like I mentioned earlier, a radical cystectomy. So this is still considered a standard of care, even for our patients. Most of the time when we discuss them at MDT, if they are candidate for radical cystectomy and they have T4 disease or they have node positive disease, most of the time they will have, first of all, neoadjuvant chemotherapy, followed by radical cystectomy. As you can see, most of these studies actually have not shown really huge difference for patients who get trimodality therapy if you compare them head to head with patients who've had radical cystectomy. The advantage of also giving trimodality therapy is that the options for radical cystectomy still stands for patients who've not gotten a complete response from that treatment. So there is no supporting high-level evidence specific to use neoadjuvant for trimodality therapy, like I've mentioned, and therefore it's controversial. RTOG 8903, is a randomized phase 3 trial by Shipley, 1998, compared trimodality therapy plus minus patients who have neoadjuvant chemotherapy. And it showed that these patients get increased toxicity and low completion rate. Like I mentioned, once you introduce neoadjuvant treatment for patients who are getting trimodality, most of them, they don't complete their treatment. So the outcome become poor. And lastly, how do we follow up these patients? Like I mentioned in my initial statement, is that patients who've had trimodality therapy you must select them well, and they must be patients who can be done cystoscopy as surveillance. So patients who are coming from deep down in the village, you know very well, they will not be able to get hold of a urology, or there's no urologist in the area, or they will not come back to the hospital, will not be a really good candidate for trimodality therapy. So because of surveillance. Yeah, so surveillance, the aim of it is to attempt at bladder preservation. There's no evidence-based schedule on how the surveillance should be done. Like I mentioned, most times we do every 3 monthly for 2 years. And then after that, it can be pushed to 6 monthly, and then until 2 to 3 years, and then yearly for life, like it's been mentioned. So these are patients who need continuous care and checks throughout. Imaging can be done every 6 months for 3 years, and then yearly. Again, they mentioned for life. This is adapted in patients who are ineligible for salvage cystectomy. There is details here on how we can do radiation simulation, and I think I'll skip this because we mentioned on how radiotherapy can be done. Most importantly, the target volume. This is details on how we actually plan our patients in the department. But I think I mentioned on the key thing to remember is that patients who are doing bladder preservation, the treatment would be, you will treat first of all the pelvis, like I'd mentioned, meaning that you're treating the bladder plus the area at risk, including the lymph nodes. Then you boost and treat the entire bladder. And for patients who have clips, you treat the area where the bladder was sitting. So these are technical aspects on how we deliver radiotherapy in the department. I will skip that. As you know, the key thing when we do radiotherapy is that we want to give the maximum dose of radiation therapy to the disease and spare the normal organ. So you will need to know which organs are sitting very close to the bladder. And as you know, femoral heads are there. So when we are assessing our treatment plan, we want to ensure that we don't exceed the normal dose that is acceptable to the femoral head, rectum, and also the bowel. So these are my references. And this is an example of how the plan for radiation therapy is. And as you can see, we treat both the lymph nodes and the bladder. So what are the outcomes of doing this treatment? You can see cystectomy alone, the 5-year overall survival for patients who have muscle invasive, like I mentioned, T2, T3 patients. You can see the T2s, and I think Ronnie mentioned clearly on outcomes based on stage, meaning patients who have earlier stage, they get better outcome. Patients who have late stage, their outcome is not that great. So patients who've had cystectomy, the T2s, there's 60 to 80%. And if you compare for patients who've had bladder preservation with trimodality therapy, you can see there's no much difference. The 5-year overall survival for the T2 is again 60%. The T3 and T4, again, you can see it's up to 40, 45. So there's no big difference between these two, although cystectomy is always considered as a gold standard. Yeah, so, and again, intact bladder after bladder preservation, you can see at 5 years, 45% of patients have their bladder preserved and function. So this is from Shipley study published in 2002. And I think this is the end of my talk, and I will hand over to Rosalind. Thank you very much.
Thank you very much, Dr. Komen, for giving us very good insights into the diagnosis and treatment, and more so on the importance of the multidisciplinary team, from the surgery to the oncologist and the nursing team. We have learned a lot, and we are in agreement that actually trimodality, as you have talked about trimodality and even the pros and cons and the outcomes, where you emphasize that on early detection, then you're able to get good outcomes. Of course, with all those information on cystectomy and chemotherapy and so much on radiotherapy. So we are very grateful for that. I know we are having questions online. I'm also requesting that we can raise our hands. Anybody with a question, please feel free to raise up your hand and ask a question. Dr. Komen, I wanted to also just add in on some situation where we've had the immunotherapy perspective, and we've been able to do intravesical BCG in some situations. So we are also doing that within our setup, and it's working very well.
Yeah, thank you, Rosalind, for that, actually. And I think my intro was a bit longer for the reason that I mentioned. I wanted just to insist, because most of our patients present late, they come with the disease that is called muscle invasive. But yes, patients who have actually very early disease, like the T1s, patients who have disease that is just confined within the mucosa and they've had surgery, yes, intravesical BCG is one of the key treatment which is available. Thank you.
Thank you very much. Ronnie, I believe you concluded, or I'm giving you a chance to answer this question. Is there a risk for oncology healthcare workers? This can be taken by both Dr. Komen and Ronnie. Is there a risk for oncology healthcare workers to interact with chemo drugs for them to get cancer at some point? So Ronnie, we could hear your response.
Yes, so the risk for healthcare workers, not only for those who work in oncology settings administering the chemotherapy drugs and radiotherapy treatments, the risk cuts across, because healthcare workers who use what we call hydrocarbons, they are using hydrocarbons, and they are not quite keen on using protective, because hydrocarbons, we are talking about the gases that we use, especially in theaters and all that. So you find that prolonged exposure and use of hydrocarbons without using a protective gear, that will expose you. But when you use adequate protection, safety is key, especially those who work in oncology settings. If you put on the safety precautions that are required, then you don't need to worry about being at risk. And even those who work in other healthcare settings where they are exposed to hydrocarbons, that should not worry them, because when they are put on adequate protection, PPE, personal protective gear, then that is okay.
Thank you, Ronnie. Just to add on, I think Ronnie has taken it the question very well, but just to mention, I think it's important to mention that, healthcare workers who work in hospitals are highly informed. And number two is that we have what we call chemosafe. So people who work with chemotherapy or work in this kind of environment, they are highly knowledgeable, and protections is one of the things that is important. So, and most of them, when they are working, they have protective gear. So this actually helps them not to put themselves at risk. Thank you.
Thank you, Doc. And also we do surveillance on where possible on many other issues that chemo would predispose to, not only bladder cancer, but any other, be it on your blood counts. So we could, that's a discussion for another day. Now there's another question here. It isn't for today, but let me bring this one to you, Dr. Komen. In T2 to 3, what are the 5-year, 10-year survival rates for the trimodality treatment? And then the other one is maybe just a comment. Does masturbation risk? Is it a risk to prostate cancer?
Yeah, thank you. Those are good questions. One, I think I think the slide just facing us was talking about the outcomes for the patients. And as you can see, patients who have T2, if they've had trimodality treatment, the 5-year overall survival is 60%. Yeah, but remember, these percentages that are given from studies do not really reflect on a patient's outcome. These are general data of a huge number of patients that have been done in a study, and they're given. So we have many patients who do so well. You will not know. This is just an average patients, how they can do. But we know many patients do well. Patients who have T3, as you can see, T4, their 5-year overall survival drops to up to 45%. So I think that has answered that question. Regarding does masturbation increase or reduces prostate cancer, I think we are not talking about prostate cancer in this talk, but just to answer that, is that there are some studies that we know the risk factor for prostate cancer is age. Being a man and getting older, it's rare to see it in patients who are less than 40, but as you climb up the ladder and God keeps you until you are older, we know if you are 100 years old, your risk of this disease is almost 100%, 80 the same, 60 in our country the same. If you're 60-year-old, you have 60% risks. But there are some studies that have shown actually that the number of ejaculation that one gets before the age of 40 protects them, actually, reduces their risk of getting prostate cancer. But this is debatable. However, it's been mentioned many times. So it doesn't have to be after the age of 40. For some reason, it's protective. Yeah.
Thank you. Thank you again. This one, either of the presenters can take it. What is the quality of life after cystectomy? And does it mean bedridden or with lots of restriction? This final question from anonymous attendee. Does it mean being bedridden or with lots of restrictions? This is not a clear question, so we are not able to take it now. So would you want to just wind up by giving us, we are coming to nearing the end, quality of life after cystectomy. Would you want to talk about it?
Yeah, maybe I can just give one comment about that, Rosalind. You know, the reason for doing bladder sparing treatment, what I've just presented actually, that we call trimodality treatment, the aim of it is to spare the bladder. As you know, the function of the bladder, Ronnie mentioned very clearly, the urine comes from the kidney, drops to the bladder, and then comes out through the urethra. So that plumbing system is affected when you do surgery, meaning that you remove the entire bladder, which I think Ronnie mentioned to us, the function of it is to store the urine. So once that is removed, it means now you have to have what we call urinary diversion. You have to divert the urine somewhere else because it can't come through the normal way through the urethra. So it doesn't make the patient be bedridden or anything, but you'll have actually another, what we call, there are different ways of doing it because the urologists do it. Yeah, there's something we call urinary conduit, ileal conduit. You'll have another bag that sits in the pelvis which drops urine into that. As I think most of us have seen patients who have done, who have had colostomy, the stool is diverted and they have bags, so where the stool goes through. Same things with the urine. So this is cumbersome to some patients and of course affects their quality of life. It doesn't mean that you'll get bedridden or anything, no, but the quality of life is affected by having those bags. I think that has answered that question.
Thank you, Doc. I remember we were also reminded that once this diversion, then the nerves that prompt somebody to pass the urine then are not able to function well. So the person who has the diversion has to program themselves to be passing urine, because then they would have a lot of urine accumulating, and that means if they don't empty it, it would accumulate maybe some sources of infection, be it bacteria, and so they have to just plan to be emptying the urine. I know we have almost concluded the questions, and I remember Dr. Komen told us that there are days you want to do a radio and cisplatin, and then we realize that the patient is having issues with the bladder, with the UECs, and so you would encourage the patient to hydrate. Ronnie, I just wanted you to comment on the care of a patient who has gone through, who is going through bladder treatment, and maybe on the follow-up that you'd give, maybe in 1 minute.
Yes, and I think maybe just in a minute, I would recommend that all of us who are on this platform to remember that it is wise for us to hydrate well, taking plenty of water has a protective effect on the bladder because it it clears the toxins. And urine will not precipitate in the bladder to form stones that are likely to also bring other challenges. Then Dr. had talked about issue with actually was just giving an answer response to one of attendees who had asked about aspects of masturbation and prostate cancer. Of course, it's still debatable, as he has said, but what we have said is, risky lifestyle also will predispose you to other conditions. And that's why the issue of more ejaculations is still debatable, because those who engage in more ejaculations and maybe take on a risky lifestyle, then they are also exposed to other conditions that might also predispose them to other illnesses. So adequate hydration is very important. And the ones who are going through the treatment for radiotherapy and chemotherapy, we recommend that they take adequate water and then adequate fluids, but water is usually recommended not at once, but regularly, so that you are able to hydrate adequately. The second thing is we also talk about those who are going through radiotherapy, skin care, the aspects of skin care. There's also aspects on how to protect yourself because some of these treatments might lower your immunity. So you need to be on the lookout on how to, like, safety precautions in public places. You have to put on masks, you have to wash your hands. So those are some of the precautions we talk about. Issues with diet. We recommend more of plant proteins, plant diets. But there's still studies that have still debatable, but some studies have shown maybe animal diets being maybe high in cholesterol, and that might also affect other systems. But we still a lot of research in that, but we recommend just a balanced diet with plenty of fruits and vegetables to improve your vitamins and minerals that you require. And then lastly, risks like cigarette intake, one should avoid them, because when you take a cigarette, then even the treatment might not be able to respond adequately as required. Because studies have shown that when you continue using the carcinogens, then you are on the treatment. Studies have shown that you are unlikely to respond better as anticipated. So we also request that those who have patients to be or support them, because the disease presents with a lot of physical, emotional, psychological issues, financial issues. You can see how Dr. has highlighted that you have to go through several tests. The treatment is not just a one-off. We have to follow you. So the cost is sometimes prohibitive. And as a family and the healthcare givers, we should be able to link the patients and the patients and maybe the caregivers to support systems that they can be adequately supported to go through the treatment and accomplish the treatment and have good outcomes. Thank you.
Thank you very much, Ronnie. As you would be thinking of what would your parting shot would be, both you and Daktari, there's a concern here on CPD points from the pharmacy team. I believe that KNH has taken note of this, and they're going to work on it. There's a question on, there's appreciation, actually, majority are appreciating the presentation for Dr. Komen and Mr. Ronnie. And this is quite informative. Can we involve the CHVs, community health volunteers, at some point? I wanted to let you know that Kenya Network of Cancer Organization has a very vibrant program that fits in the community health volunteers. And they, just before this webinar, before the KNH platform on Fridays, they do have the ones for the CHVs on Wednesdays. So we will be having this KENCO representative to just give you information how you can plug into that as we come towards the end. Otherwise, I'm very grateful, and you people have made us proud I'm requesting that you give us a parting shot, Dr. starting from Mr. Ronnie, then Dr. Komen.
So I will say that bladder cancer treatment is we have to have a multidisciplinary approach to it, because as you've seen, it has a lot of aspects, from the patient to the family, to now the doctors, the nurses, the pathologist, yeah, the social worker, the nutritionist. So it has to have a multidisciplinary approach for us to be able to combat bladder cancer. The second thing that we need to do is to avoid the risk factors, and we've talked about the modifiable risk factors. It is wise that we avoid the carcinogens. Alcohol, cigarette intake is one of the biggest carcinogen, and also to hydrate well. Hydration has a protective effect. So I believe through all of us, we need also to share and highlight that bladder cancer has a treatment. Treatments are available. So if one gets diagnosed with cancer, one should be able to come for treatment, because there is cure to cancer.
Thank you, Ronnie. There is cure. We do not need to be discouraged. Dr. Komen, please, you are.
Yeah,
from you.
Thank you, Roslyn. And dear colleague, thank you for joining us this afternoon. And thank you to the organizers of this platform. And let's continue sharing information. I think we all know that most patients present late. So I think from this talk, I think it's important to remember you should have a higher index of suspicion on patients who have bladder cancer, like Ronnie talked about the symptoms. So the other thing I think that is important is let's refer patient appropriately, so that they do not. We know from different platforms, it's been mentioned that the cause of delay for patients on why they present late is because of patients keep seeing same doctors or different doctors, or up to 6 doctors before getting appropriate diagnosis. So let's cut off that longer period and ensure that we get patients who present early. And the other thing for bladder cancer specifically, I think it is important to know that there are different modalities of treatment and not just radical cystectomy. Yeah. Thank you very much.
Thank you again. You have summarized it very well. And now we're coming to the end of our program. I would like to tell you that we've had over 1,200 people who are subscribed on this webinar today. And we've had a series. We'll be having one more on survivorship. So be on the lookout, and of course, many others, not necessarily from oncology. So be on the lookout and plug in and just learn. And let's ensure that we learn more and ensure that, as Doc has said, our index of suspicion needs to increase. And we need to refer patients appropriately. And we embrace the care modalities that are available, and also support them psychologically and socially. Sometimes this is very expensive to go through, like you heard of MRI, CT scans at some point, and then we have a lot of lab works and surgery. Somebody costed this and made it to sound like a patient may require up to 1.2 million, and that is on the minimum to get that treatment within our Kenyan system. And so we need to encourage our patients to pay their NHIF, or whichever the rates that apply to them, whether it's the new one of 300 or the 500, or even the standard that we are paying. Let's encourage everybody around us to register with NHIF and also register their relatives. You never know when you'll require this, and it's very expensive. So thank you again. As we're coming to the end, I'm requesting the KENCO team led by Madam Nancy who has been our co-host with KNH, to just come and say a word. Nancy, we appreciate you. We appreciate the work you are doing with the community at Kenya Network of Cancer Organization, and pass our regards to all of them. Thank you everyone for coming to this webinar. We must appreciate you, and you can clap for yourself. Welcome, Nancy.
Thank you so much, Rosaline. Thank you for the wonderful moderation that you have done. I would also want to thank the rest of the facilitators, Dr. Komen, Ronnie. That was a wonderful presentation. I would also like to thank the MIDIC, everyone that has participated in today's webinar. We really appreciate. Our special appreciation to the KNH team, and our main sponsor, Janssen. We will be having another session like this sometime next month on survivorship. We will communicate in advance about the details. Thank you so much for joining us today. And bye.
Bye, everyone. Enjoy your Friday. See you again another time. And nurses, enjoy the day. This was our International Nurses and Midwives Day. So let's celebrate ourselves. Anybody who works with a nurse, who lives with a nurse, appreciate them. Thank you and bye.